She suffered a injury to her shoulder. She suffered a proximal humerus fracture. Now this is an interesting proximal humerus fracture. Describe it to patients, it's kind of like the ice cream got pushed into the ice cream cone. So the humeral head got smushed into the proximal humerus. So it's an impacted proximal humerus fracture. Also the greater tuberosity is fractured here. So that's an example of a proximal humerus fracture. Interesting on this patient, we see a pacemaker, okay? That's there. Also on this patient, it's interesting to see, it looks like, oh, is this dislocated? I mean, why is that ball, the mid portion of this ball should be centered in the glenoid, and it's inferiorly subluxed. The reason subluxed is it's not dislocated, it's just subluxed, and the reason it is usually because of there's a lot of blood in here. It's full of blood, so it'll sublux from that. Also, I want to mention, this is sublux. One of the things that can happen is the axillary nerve comes out here to the deltoid, innervates the deltoid, and the axillary nerve can be injured or stunned, and that too can allow some relaxation of that deltoid. One of the things we do is when we check in the office, we always check over the sensory area of the axillary nerve. They have a nice round area over the lateral deltoid, and that'll be numb if you've had an axillary nerve injury many times. So you check for that sensory nerve to see if that axillary nerve sensation is intact. Example of a proximal humerus fracture that's fixed with a plate. So this is reduced. You can see this plate is holding the greater tuberosity in place. You can see this humeral head is centered in the glenoid much better. These are staples from closure of her skin. These are screws that go through this plate, and these screws actually lock into the plate. The great thing about locking plate technology is they lock into the plate, and even though this patient would have osteoporosis, in my day, the early days, these screws would back out of soft bone. These screws actually have threads on that thread into the plate. So they actually aren't going to back out because they're threaded into the plate. Those are called locking screws. And that has been a giant change in keeping fractures out to where they need to be so they don't collapse. All right, this young lady suffered a fracture of her olecranon. This is a comminuted interarticular olecranon fracture. This is a problem because the triceps connects here. It's pulling on this fragment and it's distracting this. So this needs to be fixed to pull these fragments together. Again, distal humerus, radial head articulates with the capitellum, and you got the ulna, which articulates with the humerus. Here's the same patient fixed. You got your staples in, you got your plate holding this articular surface back congruently here. An anatomic reduction of this articular surface maintained with this plate. This is a 61-year-old female who broke her right wrist. She, as you can follow, the cortices up. They're thicker, then they thin down. Down here you see these multiple fracture lines in this wrist. And if you look at the oblique view, it's even more comminuted. Comminuted means more than two, so more than two fragments. It's intra-articular, goes into the joint. Okay, it's intra-articular. Now here's a lateral view. This is an interesting lateral view. She actually, the average angle of the distal radius, so if you look at the distal radius, it has an articular surface that points down, or volarly, palmarly, an average of 12 degrees. Well, hers actually is pointing down a little bit more. You can see a fracture in it. So if you follow the cortice of the radius up here, you see there's a break in it, it's overlapped here. So there's a significant fracture there in that distal radius. This variant is called a Smith fracture. If you like eponyms, it's called a Smith fracture. It's interarticular. But that's important because how I fix it is I'll put a volar plate, a palmar plate on this, and push it back up, buttress it up in place. So now you can see it better. This articular surface is lined up perfectly now. This volar plate is pushing that up. It's a open reduction internal fixation of that volar distal radius, Smith type distal radius fracture. You see it's like a T plate there. This young lady, 11-year-old female, who fell at home and presented to the emergency room, left knee pain Very common for slip capitofemoral epiphysis to present after a trauma with knee pain and have it to be a hip. You have to worry about her hip. We'll see an exam that she doesn't like to weight bear, has pain with weight bearing, and the actual hip has a decreased range of motion on the affected side compared to the unaffected side. AP pelvis X-ray at the time showed a slip capitofemoral epiphysis. Now that's where the femoral head shifts off the epiphysis here. Now this is what she had. Now she's already fixed here, but this had been slipped off. So this is a single screw. The whole idea is if it's acute, it just happened, is to reduce it. If it's not acute, you don't reduce it, but you put a pin in it to keep it from slipping further. The key is to go perpendicular to, you want to be in the center of the head and neck, and on both the AP and lateral view, and you want to be as perpendicular as you can to the growth plate. So this actually goes into the femoral neck and crosses the epiphyseal plate into the epiphysis of the head of the proximal femur. And so here's the screw. You can see how again it comes into the neck, crosses this right in the center zone of that epiphysis. So that's fixation of this slip capitofemoral epiphysis. Her original injury was she was 11 when she turned 12, which wasn't even a year later. That she had an altercation with somebody, and she came in and could not weight bear on her right leg. Range of motion of her hip gave her quite a bit of pain. I treated this as another slip capitofemoral epiphysis. I felt it was quite symptomatic, and I didn't want it to slip off all the way, so I went ahead and treated her. 2 screws now. She's got one on the other side. So pin both sides, same principle on both sides. Other things that can happen, sometimes there isn't an obvious trauma. Sometimes they slip because they're obese or they're, we get the typical what they call a Fromlich, F-R-O-M-L-I-C-H. Basically where you kind of get like you're overweight and skeletally immature, and so you develop a slip capitofemoral epiphysis in that situation too, which we see. So you just have to be aware of those things.